Okay, so there's a few different receptors that pressors have. We have alpha receptors, beta receptors, V2 receptors, and dopamine receptors. And then there's a couple mixed ones. So there's one that's alpha more than beta, and one that's more beta than alpha. So each one of these pressors has a different reason for use. So we're going to change color. So the pure alpha, the pure alpha pressor is called neosynephrine or phenylephrine. So you'll heard it called neo sometimes, so don't get those two confused. So this is pure alpha. You need to remember this is a weak pressor, and this does not affect your cardiac output. So you're going to see this a lot. Our anesthesia colleagues like this because a lot of their sedation causes relaxation of the arterioles. So this is a way that they can get that squeeze without affecting their cardiac output. Then on the other side, the pure beta agonist is dobutamine. And these are things that you're mostly going to be seeing in the CV-ICU in places where they have cardiac patients. You're not going to see a ton of that in the surgical ICU. When we look at alpha more than beta, we're going to get kind of our go-to pressor within the ICU, which is norepinephrine. Also known as Levo, which is the trade name. So this is going to be your first line for sepsis. So you want to look at your surviving sepsis guidelines, and this is going to be one of your first line things, along with cultures, lactate, antibiotics, and fluid bolus. And I think about this, when I think about using Levo, I think about this as a dial. This is something that's really easy to titrate up and down, where other pressors I think of a little bit differently. Beta more than alpha, this is your epinephrine, or epi. And this is for codes, anaphylaxis, and kind of a last line for people that aren't doing very well. Under V2, we have our second line drug for sepsis, and this is vasopressin. This acts on the V2 receptor. This is a second line drug. You're not commonly going to use this starting out of the gate. And I think about this as a switch that generally when I'm treating a patient that's hypotensive, I'm going to give them, start with Levo because that's something that's very easily titratable, where just the way that vasopressin functions, it's something that takes a little bit longer, and so I usually go up a little bit on my Levo once I get over a dose of either 0.1 or 10, depending on how you set your pumps. Go to vasopressin, turn that on, go up on the Levo after that, and then when you're coming down, you come down on the Levo, and then when you pass that line again, you can turn your vasopressin off and then come down on your Levo. The ICU is a complicated thing, but if you break it down to each little step, you should have a pretty good way of thinking of each of these steps. So pressors should not by themselves be complicated. And then last on the list is dopamine. So this is the one that has those dose-specific effects. This isn't really used a ton. Some people use it for renal perfusion. That's not something that everyone does, but it's something you should just know about. And most of the time, if you're going to be using this, you're going to have an attending that's going to be directing your care. But that's a quick and dirty overview of pressors.